ALT is highlighted over AST. Patients with alcohol-induced pancreatitis will conversely have consistent lab findings with alcoholism. This includes an AST to ALT ratio of greater than 2 to 1. A toast to elevated AST. Alcoholic patients may also have macrocytosis, measured on CBC as an MCV of greater than 100. Yup, big red blood cells, just like the big red flowers on that overtly touristy Hawaiian shirt. Sometimes you'll even be able to measure an acutely elevated serum alcohol level. Don't worry, we'll go over AST and ALT in much more detail in our liver enzyme sketch. A common complication of acute pancreatitis is the formation of a pancreatic pseudocyst. Remember, autodigestion of the pancreas causes large amounts of pancreatic secretions, chock full of digestive enzymes, to be released. The presence of these secretions produces an intense inflammatory reaction, leading to a liquefied mess of necrotic fat. Eventually, the liquefied pancreatic tissue is walled off by a capsule of fibrous granulation tissue. Yup, just like the liquefied core of these fibrous coconuts. Pseudocysts on me, everyone. Wait, why is it called a pseudocyst? Technically, the walls are not made of true epithelium, which would make it a true cyst. Instead, there's a layer of granulation tissue, rife with fibroblasts and neovasculature. Pseudocysts usually spontaneously resolve, but watch out. They can become secondarily infected or even leak into adjacent tissues. Sometimes in severe pancreatitis, blood flow to the acinar cells is compromised, which causes further autodigestion and progression of the disease to acute necrotizing pancreatitis. This is a bad sign, as you can probably tell from the ominous necrotic tiki statue over here. The necrosis can extend beyond the pancreas itself and spread to the surrounding retroperitoneal fat, omentum, or mesentery. Macroscopically, this will show up as white, chalky areas of fat necrosis, represented here by the chalky white-colored skulls across the tiki statue's abdomen. Acute necrotizing pancreatitis causes hemorrhage as well, and on gross pathology, you'll see red-black hemorrhagic areas. Extensive necrosis can even lead to diffuse hemorrhage within the pancreas, a poor prognostic indicator that carries a 20% risk of mortality. Infection with gut bacteria is also very likely in acute necrotizing pancreatitis, often leading to septic shock. It's just badness all around. While we're on the topic of mortality, one of the worst complications of pancreatitis is the development of acute respiratory distress syndrome, or ARDS. Wait, pancreatitis leading to lung damage? What the Kyoki o Niuhai? Yep, autodigestion of the pancreas results in the release of phospholipase into the bloodstream, which then travels to the lungs and breaks down surfactant. Massive pulmonary edema ensues. On imaging, you'll see diffuse bilateral opacities completely white out the lungs. Hence our recurring sketchy symbol, the great white ARDS shark, this time prowling the waters off the Hawaiian coast. Finally, one last important complication of pancreatitis is splenic vein thrombosis. See that jellyfish that's washed up on shore? Kinda spleen-shaped? With tendrils that evoke an image of the splenic artery and vein? Well, these vessels run right behind the pancreas, and inflammation in the overlying organ can cause blood clots to form in the splenic vein, as depicted by the thrombotic, fibrous skirt worn by the hula girl stepping on that splenic sea jelly. Splenic vein thrombosis causes pressure to back up into the gastric veins, leading to gastric varices. Watch out, because when those varices rupture, your patient will come in with hematemesis and dark stools, sure signs of an upper GI bleed. So how is acute pancreatitis treated? Essentially, there's not much we can do. Treatment for most cases revolves around preventing further release of pancreatic enzymes by keeping the patient from eating for a couple of days, IV fluid and nutrition replacement, pain control, and antibiotics if a concomitant infection is suspected. Once the acute phase is over, the next step is to treat the underlying cause of the pancreatitis. This can mean cholecystectomy for gallstone pancreatitis, alcohol cessation counseling for alcohol pancreatitis, or fibrates for familial hypertriglyceridemia. Long-term or recurring insults to the pancreas inevitably lead to irreversible damage to the pancreas, the hallmark of chronic pancreatitis. The most common known cause of chronic pancreatitis is chronic alcohol abuse. And you know how tourists get. chronically drunk when they should be taking in the scenery and rich culture of Hawaii. Mea he mea hila hila. It looks like a few of his friends are certainly enjoying themselves, though. Idiot. Nah, it's just a well-thought-out gag full of sophisticated humor. Let that idiot sign on his back remind you that many cases of chronic pancreatitis are, in fact, idiopathic. In other words, we have no idea what's causing it. Another important cause of chronic pancreatitis to know is cystic fibrosis. In CF, thickened pancreatic secretions, similar to those of chronic alcoholism, cause obstruction, inflammation, and eventually lead to chronic pancreatitis. Check out our CF video for everything you need to know about cystic fibrosis. The main theme in chronic pancreatitis is parenchymal fibrosis, leading to chronic duct obstruction and long-term inflammation. Eventually, the pancreas can't take any more of this and starts to atrophy and calcify, as depicted by the sea sponge that's washed ashore, dried out, atrophic, and I definitely see some fibrosis there. Just in bad shape overall. Calcified concretions can be seen throughout, as depicted by the calcific white flowers that adorn his Hawaiian shirt. A very helpful clue for diagnosing chronic pancreatitis is the visualization of calcifications within the pancreas on CT or ultrasound. Just like in acute pancreatitis, a pseudocyst may be found on imaging as well. So let's draw in our symbol for pseudocyst, a fibrotic coconut capsule surrounding a liquefied juicy core. Sounds refreshing, right? Over time, pancreatic acini are lost, resulting in some major exocrine dysfunction. Without any lipase in the GI tract, for example, patients develop steatorrhea, or bulky, frothy stools due to the high fat content. Yeah, that's not just seafoam in the water there. Patients will also have weight loss and deficiencies of the fat-soluble vitamins A, D, E, and K. See that dilapidated dock in the back? Yep, it's our recurring ADEC dock, emphasizing the GI loss of the corresponding fat-soluble vitamins. Eventually, chronic pancreatitis ends up destroying islets of Langerhans as well, which means say goodbye to endocrine function. This can manifest as insulin-dependent diabetes. So above our trash tourist here, we've drawn in some elevated candy lanterns in order to highlight the chronically elevated blood glucose seen in the setting of diminished pancreatic insulin production. Unlike acute pancreatitis, amylase and lipase don't really give us much useful information when it comes to chronic pancreatitis. In end-stage disease especially, loss of exocrine and endocrine function means that you will not find an appreciable amount of pancreatic enzymes in the serum. Therefore, diagnosis of chronic pancreatitis is made almost exclusively by the patient's history. One last thing to note. All that chronic inflammation in the pancreas increases the risk for pancreatic adenocarcinoma. So watch out for those cancer crabs. That's for the next sketch, however. So let's bring this luau to a close, shall we? To recap, pancreatitis comes in two flavors, acute and chronic. Acute pancreatitis is most likely going to be caused by a gallstone blocking the ampulla of Vater and causing autoactivation of trypsin. Like an automated meat cleaver, it starts hacking away, leading to abdominal pain, nausea, vomiting, some sizzling fat necrosis, maybe some hypocalcemia, and hypovolemia if the tide is right. This liquefied mess of necrotic fat is eventually walled off by a capsule of fibrous granulation tissue, as evoked by that fibrous coconut beverage. Phospholipases can also travel up to the lungs to cause ARDS. Whoa. Don't forget about the revelers either. If alcohol is the cause of pancreatitis, expect an AST to ALT ratio greater than 2:1. A toast to elevated AST. Speaking of alcohol, it's the #1 cause of chronic pancreatitis, marked by diffuse parenchymal loss and fibrosis and calcification, and eventual pancreatic burnout, just like that sad, shriveled sea sponge in the back there. Expect a lot of the same complications in chronic pancreatitis, compared to acute. The big thing to remember with chronic, however, is loss of exocrine and endocrine function, leading to malabsorption, weight loss, and even diabetes. Chronic pancreatitis can even be a risk factor for pancreatic adenocarcinoma. So keep the sunscreen handy, because we're headed to the next island over, where we'll meet a ragtag group of castaways who embody all that is pancreatic cancer.